on this episode of RPA.
Pulled my leg up to my chest to scratch and a big tumour sat in my hand.
Saving young mum Jolene.
You want to be there for those kiddies?
Yeah.
Well, if we don't cut this out, you're not going to be.
Actor James
When I don't come through, it doesn't matter.
takes centre stage for the performance of his life.
We're trying to put 10 stitches in a 1 millimetre blood vessel.
And Oliver is about to find out what's really wrong with this picture. A young family are coming to terms with some devastating news. 2 years ago, life changed forever for 43-year-old Jolene, her husband Craig, and their 3 little girls.
I just felt off, real sick and tired. And then one night I was laying in bed here and I had an itchy leg, so I pulled my leg up to my chest to scratch in underneath, and a big tumour just sat in my hand.
Within weeks, Jolene was on the operating table having the cancer removed.
Wasn't attached to anything, so I was very lucky, and it came out as 1. 10 months later, it was back. So we were shearing our sheep, and I was picking up the fleece, and yeah, I just could tell.
Jolene's second operation was also a success, but now the tumour is back for a 3rd time.
You get a bit weak when you first get diagnosed again, but build a bridge, walk it. You can go back there and give him a workout if you want to.
Jolene's husband Craig is riding every bump with her.
It's a battle. It's been a bit of a battle, but we'll get through it. Yeah. Yeah, Mum's a rock. I try to be Mum's rock, she beats my rock, so it's about best I can put it. Yeah. Does get a bit out of you going sometimes, but we just keep moving forward. Yeah.
Nearly fire time. Can't wait for the fire. Hey, girls. So I got my 3 little girls to fight for and everything else yet. It doesn't really feel real to me, you know what I mean? But there's not much I can do. I can't just lay down and let it beat me. I just got to put one foot in front of the other and poke along and spend a bit of time with the girls and the horses. It's always good therapy, that's for sure. Nice. Go.
Yeah, the kids they've got an idea that Mum's going through a battle, and yeah. They not too much of the ins and outs, but they definitely know something's wrong.
Do you reckon you'll leave your heaps of Easter eggs?
No.
Mum is just sick. Mum's got to have an operation. They know that it's cancer, but do they really understand the term of cancer, if you get me? And I just deal with one thing at a time. So, yeah, hopefully we can beat it. Yeah.
They'll make the long drive to RPA tomorrow for Jolene's life or death surgery. In emergency, 17-year-old Oliver has been forced off the rugby field with a not-so-funny injury to his funny bone.
I received the ball and I kind of tried to fend off my opposition, and I could just feel straight away that kind of, it just felt off straight away as soon as I did it, and I was like, yeah, this doesn't seem good.
We can see something's not quite right here. That bobbly bit's supposed to be in that hole there. So we call that a dislocation. The joint's out of place. And our role here is to pop that back into there.
I mean, I think I played okay, but there are a few things I could have done better.
There'll be plenty of time for a full match report, but right now, a different type of game is about to commence.
I'm just going to give him 50 of fentanyl now. 50 mics going in.
A lot of reductions, that means improving a dislocation, are done with providing a little bit of pull or pressure. Sometimes so someone will be pulling from the fingers, and also someone might be providing counter traction. That means, if I can use your arm, someone will be pulling towards me, and we might need an assistant also pushing from the other way. So pushing that bone that way as well. And so a bit of a pull on there and push on there. And hopefully it will clunk into place, especially if Oliver is relaxed.
So he's already had 50 of fentanyl. I'm going to be giving him another 40 of propofol now. Keep your eyes open. Keep your eyes open. There you are.
looking for him to be less stimulated. So at the moment, when we're saying eyes open, he's opening his eyes, and we want him to be a little bit more asleep than that. How does he react to you manipulating the arm? Yeah. Do you want to see how you go with a little bit of traction?
No. 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 No.
Give me another 20.
No.
Jolene and her husband Craig have made the trip to RPA for a sit-down with the two cancer surgeons she hopes will save her life.
This is the first time I've seen you in the office because we've operated.
Yes, you look very different to the operating theatre, yes.
The positive message that I try to give the patient that this is not the end. There is a way that we can help them, and we are going to be by their side. We'll be with them, help them all the way.
Yeah, and you know Paul because he did the first one.
Dr. Sterling.
You must never, never give false hope. That is absolutely unconscionable, in my opinion.
So back in mid of 2020, Paul did a biopsy, found that it was a liposarcoma, and then you had surgery in July. What kind of symptoms are you experiencing at the moment?
No, I'm pretty good, I think. A little bit tired, that's around about it.
Yeah.
I try and keep going, mate, 1 foot in front of the other.
In the end, it's about helping people with surgery. That's the joy that I get.
And what about walking? How's the walking?
Oh, I've just got me limp, yeah. Yeah, I have me days. Some days their legs are good and other days they don't put up with much.
Yeah. All right, Paul, do you have any questions you'd like to ask?
We've operated on you twice before, and this thing has come back. Yours looked like it was a low-grade one to start off with, but it's behaving in a more aggressive fashion. And lo and behold, we find you've got a big something back in your groin again. And that's why you're here. If we do nothing, this tumour has shown already that it's going to grow aggressively. So we need to remove it, all of it, all the way around it. And when we can do that, we have some chance of saying we've got control of it. You have to emphasise that there are things we can do about it, and this is what we're going to do. You're a bit of a naughty girl.
Why?
Well, you've got it in a place which requires a lot of effort to get it out. It's in a difficult...
Doc. You left it there.
That's right. That's exactly right.
Yeah.
The problem with these tumours is that they often have little satellite areas around that we simply can't see. That's why we've done all those subsequent scans looking for it, and sometimes we find it. And in your case, we have. Now, it's growing rapidly.
Yeah.
So the aim here is to remove the tumour with margins. So we need clear margins. We don't want to see tumour when we take it out on the surface of where we cut it, because then we know it's going to come back.
Yeah, exactly.
So we want some good margins.
Yeah.
So this possibly take more than one surgery?
Oh, no, I think we'll do it in one
surgery.
day. Yes, one surgery.
Yeah.
And then...
It's just a matter of getting on the table and getting it done and see if he's pulled it off.
It'll take as long as it'll take.
Yeah.
6, 8, 10, 12 plus hours, doesn't matter.
Yeah, it doesn't matter, that's right. Just get it out, please.
We have to get ahead of this tumour on this occasion. You've had much to do with Jolene, you'll know. She's got that lovely, yeah, doctor, she'll be right, mate, let's get on with it. And husband's very much the same, salt of the earth. And you meet people like that, and they're just a delight to look after. You tell them everything, you don't hide anything from them. If you can improve those results, it's like getting up and winning the lottery.
What would be the worst case scenario?
Well, the very worst case scenario is that she would lose her leg on that side.
Straight up down the lane.
Yeah.
Straight down the line. You
I
did say you wanted me to tell me what it was.
Yeah.
You want to be there for those kiddies.
Yeah.
Well, if we don't cut this out, you're not going to be.
Without urgent brain surgery,
Come on through this way.
71-year-old James could die at any minute.
Remind me how you discovered these aneurysms.
I started becoming aware of headaches about July, August of last year, and they seemed a bit frequent. And then eventually I rang my GP, and he probably saved my life, I suppose, because he said, well, you know, let's get a scan. And that was when we discovered that I had these 4 aneurysms.
I like the brain, I like the complexity of it. It's a high-pressure job, but I kind of like that as well. And it's also something where you can really make a difference and help people. As you know, having aneurysms like this, the main problem is that it can burst.
Yeah, of course.
And if it does, a third of people die suddenly, and then a third of people are disabled, and only a third of people get through in good shape. Tell me about the family history.
I have subsequently spoken to my sister, who reminded me that 2 of my first cousins, both quite fit men in their 40s, had aneurysms undiagnosed and had died from burst aneurysms.
So that's quite a strong family history.
Well,
really.
yes.
But despite the enormous risks and disturbing family history, James has no intention of slowing down.
Well, I'm an actor. I first came to Australia as an actor many years ago, back in the 1980s.
For years, he was completely oblivious to the time bomb hiding in his skull. But not anymore.
If you get the mother of all headaches, what they call a thunderclap headache, I think, you've probably got about an hour to get yourself to A&E for some treatment, because it probably means the aneurysm has burst and you'll get bleeding on the brain. I've had my bag packed, ready to go.
So if you look at a typical artery as it comes into our brain, it divides into a normal vessel.
Okay.
But sometimes we can have this scenario. So the blood is flowing in this direction, and it pushes up against the wall.
Right.
And it might form a weakness. And then as blood continues to push against it, it can get larger and larger. And of course, then it could burst.
Yeah.
Which is what we don't want to happen.
Of course. Can you point or even touch where they are in relation to the front of my head?
4 centimetres.
That's the big one.
4 centimetres from behind here.
Oh, okay.
They're all 3 of them on the left.
Yeah, yeah.
And
okay, so the 2 of them in there somewhere, plus the anomaly,
yes.
plus this one.
Yeah, then on the other side, where your finger is, about 3 or 4 centimetres in there, that's this one.
Yeah, yeah.
Which we won't treat through the same approach, but we can look at treating at a later stage.
Yeah. So you make an actual hole, you take some bone out and
We
then
take out
put
a
it
piece
back?
of bone about that big,
Okay.
which is sort of sitted here,
Okay.
and then we put it back at the end.
Gosh.
We can directly influence people's lives by doing things with our hands. You just have to know at the end of the day you've done your very best for the patient, and the great thing is that if the patient does well, you go home and it's the most satisfying experience you can have to help someone. With multiple aneurysms, you've got a higher risk of it bleeding.
Sure.
With an irregular aneurysm, which you do, there's a higher risk of it bleeding, and I think we ought to treat it.
Yeah.
Jolene's big day has arrived. Pre-surgery scans have revealed 3 smaller tumours in her abdomen, as well as the big one in her pelvis. They all have to come out.
Can't believe it's happening again.
Jolene?
Good morning, Dr. Lee.
How are you going? Already?
Yeah.
It's so rewarding that I can remove this cancer and then put things back together again to improve their quality of life, their function, and their survival.
Great. Nice to see you again. How was your stay?
You ready?
I'm good. I'm fresh. Any questions?
Nope.
Do you understand the plan today?
Yep. Big margins.
Big margins, take it out.
Yeah.
But give you function.
Yeah.
Yeah? As much function as you can have.
Yeah.
All right. We'll see you when you get up.
Aye.
All right. And I'll give you a call by the time when we're about to finish, okay? All right. I'll see you in the anesthetic bay. Okay, see you.
Removing that C word for them, it's uplifting and a sigh of relief for the patients. And I feel very lucky and blessed that I can do that.
My name's Fergus. I'll be taking you through the theatres today. If you'd like to say goodbye now, we're just going to take you through.
Bye, babe. We got this. Bye.
Today's surgery is so complicated that another of RPA's most experienced specialists, Dr. Stelly, will be operating alongside Dr. Lee.
It's a bit like planning a D-Day landing. You've got to think about it. You've got to plan it in advance. And then come on the day, we may actually do something slightly different. It's unknown territory. Nobody's ever had probably a resection like this done before. You just have to play it by ear, but you get used to doing that. That's just the way it is.
That's the mass there. Now, the decision is whether to take this off the bowel or I think we might have to.
I think that's it. Well, this is the first little complication. Well, the little deposit in the belly is firmly attached to the bowel.
No, not really. It's not attached. Yeah, I think it's just got its own adhesion. There's no invasion of this lesion.
Good. Oh, we don't have to take it.
Yeah.
It's a promising start, as the initial tumour is removed more easily than first feared.
Many of these decisions can only be made once you're in the tummy and you can actually see what's going on.
So it's got a bit of like a few millimetre margin on it. So that's the fat margin that we wanted to see. Okay.
1 down, 3 to go.
You have to have this passion for surgery to do it because it's intense. I find it so rewarding that I can operate on a patient. It's a privilege that they have this trust in you after just 1 or 2 consultations that you're going to remove this cancer for them.
So this is the second peritoneal deposit that we saw on the MRI scan. It looks like it's just attached to some fat of the bowel. It's going to be very gentle here. And that's the fatty tissue margins we got on it. Okay?
Dr. Lee and Dr. Stelly have now successfully removed 2 tumours.
There's another one in there. So we're going to have 3 intraperitoneal lesions. So get that, move that back for me there. Okay, another one. Just give us the jar again. So this is the 3rd lesion, and that's the peritoneum or the lining within the pelvis, and that's to get that margin. And you can see there's this normal tissue there, and then the tumour there. So that's our margin.
This one's a big one. This one, I don't know, we've probably been more concerned of how it's been built up sort of thing, so yeah. But yeah, no, we'll be looking at each other tomorrow and looking for a laugh. Trying to find one anyway, so best we can.
We've mobilised the bladder, the rectum, and we're now onto the pelvic floor. And this tumour is below the pelvic floor, and it's a fatty tissue, so I'm going to try to expose that now.
But as they close in on their main target in the pelvis, they make a worrying discovery.
Pelvic tumour. We've seen some abnormal tissue in front of the bladder. So in this scenario, because we want to get this margin correct, we'll send it off for a frozen section, which means we send a bit of tissue off fresh, and we ask our pathology colleagues to have a look and to tell us whether it's tumour or not. If it is, then we're going to take the bladder.
Dr. Lee asks for the testing to be done immediately.
Okay, let's send that off. Get a retake, thanks.
While the tissue is being analysed in pathology, and with questions still hanging over whether Jolene will be able to keep her bladder, Dr. Lee and Dr. Stelly locate the major mass in Jolene's pelvis.
That's a tumour there.
And it's now clear to them it won't be easy to remove.
The bladder is actually very stuck.
To make matters worse, the results from the tissue just sent for urgent testing in pathology are phoned down to the theatre, and the news is not good.
So they're highly suspicious there may be malignancy there.
Okay, thank you.
Daniel. Give me another 20. Daniel.
So what
what are you
is anything moving?
doing?
So I try to pull a little bit from here. Yeah, okay. A little bit off on the thumb, on the arm. Oh, lovely. So there's a nice clunk there. Yeah. Okay, now let's plaster it up. If we look at the elbow, it's got a nice point at the end and can flex and extend normally. Okay, so we know it's back in place.
It's been a tough day for Oliver, but for now, he's only focusing on the positives.
It felt like I got a good sleep, but Yeah, I hope it wasn't too long, otherwise my mum's going to be up waiting for me, but yeah. It was a good sleep, for sure. I didn't feel it when they popped it back in. No, I'm just so happy. I didn't feel anything at all, really.
He was playing rugby, yes.
As his mum arrives in the ED, hoping to take him home,
There he is. Hey, buddy.
Oliver's given one last quick check.
Any pins and needles or numbness tingling in the hand? Can you feel me touching you here? Under here? And here? They all feel normal? Yeah, very good. Cross your fingers over and spread them out really wide. Okay, fantastic. And as you said, your cuffs at the moment, not in too much pain.
Right.
Okay.
Feel okay?
Yeah, a lot better than
A few hours ago.
No worries.
Worth the wait, hey?
Okay, no worries. We'll send you home then.
Okay.
No
Thank
problem.
you so much. Yeah, I'll get those. I'll get those.
Oliver will be sidelined for 6 weeks, but at least he gets to go home, where he'll be looked after by his own private nurse, Mum. After 6 hours of operating, Dr. Lee and Dr. Stelly are closing in on the potentially fatal tumour attached to her pelvis.
We went through the abdomen, went down to the pelvis, took out 3 nodules that we were suspecting to find. They had been removed. And our next job was to locate where the tumour was and not the structures around it. The main tumour is the size of a grapefruit, the size of my fist. It's attached to the pubic bone. Paul has already freed up the midpoint, the front part of the pubic bone. Now what we're going to do is go out far left of the tumour to get that margin laterally, cut that bone, and then go deeper. And then the whole specimen, which will probably be the size of a football, will all come out. And then the reconstruction begins.
But there's some good news. After further urgent testing, the extra tumour they discovered earlier has now been cleared by pathology.
There was a fatty or lipomatous-looking tissue that was adherent to the bladder, and I was worried that this was tumour recurrence. We sent a bit of that tissue off. That has come back as most likely dead fat tissue rather than liposarcoma. So that was reassuring, so we can repair the bladder and not take it out.
As the clock ticks over the 7-hour mark, the large tumour is finally removed.
So the removalists have been, and now the interior designers have come in. We've got to do the reconstruction part. We've taken so much muscle out, there's going to be a dead space there. The body does not like empty space. Anywhere in the body, we'll fill it with fluid. So we're trying to close as much of that dead space by using muscle flaps. Her natural tissues.
Getting that out is exactly what we were trying to do. With great big tumours in confined spaces, you may make a little nick in the capsule around the tumour from time to time, and we did that in a couple of places, but we knew it, and we cleaned it and washed it out, and we think our margins look pretty good, certainly as good as they could possibly be. She will now be pretty sore and miserable for a long period of time. We have to make sure that a femoral nerve and a sciatic nerve are actually working properly. And if they are, she should be able to walk pretty well.
What procedure are you having today?
I'm having a craniotomy so that he can clamp my aneurysms.
Okay, Jamie, off we go, buddy.
An aneurysm is a weakening or ballooning of the wall of an artery. One can be deadly. James has 4 of them.
I hope you enjoyed this process. It's
enjoying it so far.
As voices go, they don't come any smoother than surgical anaesthetist Dr. Chris Thompson's.
When a person comes to an operating room and they're thinking, you know, this might be the last time I ever get to speak to somebody, that's a big responsibility for me. So I'm very mindful that that interaction has to go really well. I've done neurosurgical anesthesia for about 40 years now, and I'm always impressed by the courage of people who come for big operations like this. So every time when we go to sleep, I reflect on that and try to encourage the person to feel that they're in a very safe place and surrounded by people that care about them and that everything will be okay. Just take this away now. And even if perhaps at times I know that it's not always going to be okay, I think it's tremendously important for a person to feel that no matter what happens, we're there for them and that we care about them. And I get a bit emotional about it because it's really quite hard when things don't go well.
I can't tell you how exciting this is. It's an experience, you know. And if I don't come through it, I know this probably sounds glib, but if I don't come through it, it doesn't matter. I've had a long and really interesting life.
Anesthetics is a mystery, really. As the drugs kick in and a person drifts off to sleep, it's quite wonderful to see where they go. For a lot of people, it's going back to their childhood, to happier memories. In his case, it was the 60s. His focus as he went off for this massive operation wasn't the operation. It wasn't the fear or the worry. I was just, here I am with some friends and we're thinking about the 60s, you know. To me, that's a lovely way to go to sleep.
The neurosurgeon leading the team today is Dr. Rodney Allen.
I think it's a great privilege to operate on someone's brain because you're operating on their personality, on their thought processes, and they're letting you operate on the part that makes them a person.
The main concern with operating on an aneurysm is to make sure that the aneurysm doesn't rupture during the surgery, which can happen sometimes, and obviously that can be a disaster if it happens too early, and that we preserve all the arteries that come in and out, because if we don't, James will have a stroke.
To prevent this, Dr. Allen needs to cut off the blood supply to each aneurysm with tiny clips.
So we're just starting James's operation now.
The first step is to remove a small part of the skull, including the eyebrow bone.
So this is the piece of bone that's, we can remember this, the brain under here. Hit the bright care button. And we can just see some arteries starting to appear now. What you can see here is that there's some cholesterol buildup in this artery here, which is the middle cerebral artery, and we can see the first of the aneurysms, I think, just down there. So now we'll head across towards the largest. There's an aneurysm here, and then there's this other aneurysm, this ugly-looking thing that's sticking right here. So what we can see now is we can see the bigger aneurysm just starting to appear where the lasers are, that yellow thing there. So we're going to put some temporary clips on to block the blood flow off.
The clips he uses are mere millimetres in length.
So we put on a clip and we've got blood flow in all the arteries and no blood flow in the aneurysm at the moment.
I think that being any sort of surgeon, you have to have a very razor-sharp focus so that you can deal with what's in front of you. Because, I mean, if you think of neurosurgery, we're dealing with things that are a couple of millimetres across sometimes, and we're trying to put 10 stitches in a 1 millimetre blood vessel. You need to be able to focus on something very carefully.
All temporary is off and a permanent clip's on the aneurysm. So now we're going to inject something into his blood, which will make all this light up, and then we'll see if the aneurysm's still filling.
You say when, Rod?
Yeah, not yet. So I've got that's off now, right?
Okay, now it's off.
Can you see anything?
No. Oh, yeah, now we've got flow. Yep.
So I think there is filling of the aneurysm, though, isn't there, or not? Maybe not.
No, there's no... Yeah, the aneurysm's dead, so the...
Yeah, and you can see the artery?
Yeah, we can see the artery, and it looks like it has flow, yes.
Good.
Yeah, it's alive, yeah.
Okay, cool.
Yep,
That's good.
Good.
Yep, all good.
All good.
So you can see on the field, I think you can see 3 clips now. So there's clip on an aneurysm here, a clip on an aneurysm here, and the bigger aneurysm clip is in the depths down there. So the next step is just to reconstruct James's skull and his orbit. But otherwise, we've finished with the hardest part of the operation now. I think it went okay, and everything went routinely and smooth, but we won't know until he wakes up exactly how he'll be. So he'll go to intensive care shortly, and I'll probably see him in the morning when he's fully awake.
1, 2 or 1, 5? Great.
He'll probably be in hospital hopefully only 4 or 5 days. But it will just depend how much of a headache he gets and how he feels when he wakes up.
After 16 hours of surgery, Jolene has had 4 tumours removed from her pelvis. With the reconstructive team now in charge, Dr. Lee wastes no time calling her husband.
Hey, Craig, how you going?
Good, thanks. Yourself?
It's Dr. Lee here.
Hey, Dr. Lee, how are you, mate?
Good, good. Engaging the family, being there for them, I think is very important because I can imagine how stressful it is just waiting to see what the outcome is. So it's important to call them, keep them up to date, and tell them how the surgery went and how I feel about it. I actually found 4 nodules. I've removed all of them. And then we've taken out the main one with the bone. So I'm happy that we've got the whole tumour out and all of the other nodules. And we're just going to finish off with the reconstruction part, and that's going quite nicely.
Yeah, no worries, Dr. Lee. No, that's very much appreciated, mate. I'll take my hat off to you guys. What can I say? It's brilliant. The work you do is absolutely brilliant.
Okay, my pleasure. We'll see you in the morning, okay?
Thank you very much.
All right, see you. Bye-bye. Good night.
71-year-old actor James is recovering after a delicate operation to remove 3 volatile aneurysms in his brain.
Jay, welcome back, mate.
And the last face he saw pre-operation, anaesthetist Dr. Chris Thompson, is also the first one he sees as he wakes up.
We're in our recovery room now, mate.
I've been involved with anaesthetics for 40 years, and we've progressively moved from recovery rooms where people were vomiting and unwell and sore and groaning, and it was a bit like a horror movie, to the modern recovery room where most people are quite comfortable sitting up sprightly and wake up quickly and cleanly and well. And that's what these modern drugs let us do.
Yeah, operation's all finished. Yes, it's finished. We don't leave someone in recovery until we're 100% sure that they're good. And it's a little contract that I have with the patient. Regardless of anything, it doesn't matter how old they are, how young they are, how rich or how poor or whatever. That's what I do for everybody. You know, I just make sure that while they're with me, I'll take care of them.
Hang on. Have I been operated on?
Yes.
Oh, OK. So that operation's over?
Absolutely.
Oh, OK.
I was going to say, ask you if you had a nice sleep, but I can see that's a pointless exercise.
Well, I don't think I didn't feel I had a sleep. Well, OK, that's good. Yeah.
But I think anesthesia is really about making people feel secure and safe, and then following up on that promise the whole way through, the whole time, never letting up. Like, you know, like the Terminator in the, just being 100% focused on them and only them. Sit by their side, watch every breath, hear every heartbeat. All right, look, you get a good afternoon's rest and everything's going very well. All righty?
Yeah, thank you.
Any questions at all?
I can't think.
Okay. Well, have a good night, okay?
Thank you.
Been a pleasure looking after you.
Thank you.
It has. All the best.
Thank you very much.
You're welcome. That's all good.
The next day, neurosurgeon Dr. Allen drops by to take James through his surgery.
So yesterday, as planned, we took off all the bone, including your eyebrow bone, which is why you've got the black eye. And I went under the brain and found all 3 aneurysms, and they were all clipped and they're all collapsed. And your scan now shows no filling of any of the aneurysm.
Wow.
So they're all fixed.
What about those there were a couple of other little anomalies?
They weren't aneurysms.
They weren't, OK.
No, it was just the 3 on this side.
Yeah.
And there's still the 1 on the other side, but we'll deal with that. And otherwise, yeah, you're looking good.
Good.
So, James, if you hold your hands up in front of you like this, palms up, nice. Hold them still. That's great. You can open your eyes up and put your hands down and just show me how your legs are working. Good man. Put them down. And in terms of recovery, you may feel a little bit tired now, but I would think in the next 2 or 3 days you'll be ready to go home.
Good.
The thing about being a doctor is that it's the only, or one of the only jobs where you actually get to help people every single day because we can directly help people. It's the best job you can have.
have a nice weekend.
Thank you
I'll
very
see you,
much.
I'll probably see you next week before you go.
All right.
See you then. Bye-bye.
Thank you, Doctor. Bye.
It's the day after Mum of 3 Jolene's marathon cancer surgery. All 4 of her tumours have been removed. So relief, followed closely by exhaustion, fills the room.
Very, very tired, very, very sleepy.
Said she was asking for me last night. They don't really yell at me, I'd imagine, but...
I don't even remember last night.
You know, the nurse said you were asking when you were coming out of surgery.
From our first consultation, I knew Jolene wanted to preserve the leg because of her functionality at home, what she needed to do as a mother, and she loved to watch her children with their sporting activities and needed to drive them there.
So how are you feeling?
Yeah, all right.
Yeah?
Just tired.
Yep. You had a long day yesterday?
Very tired.
Yeah. How's the pain?
Yeah, good. No pain.
No pain? Okay.
But I haven't moved, neither.
Yes. We've got to keep you in bed because of what we did. So I'll go through that. So yesterday, as we planned, was to get the tumour out.
Yeah.
I actually found 4 lesions within your abdomen. They've been all removed. And the really good news is you have a functioning leg.
It all comes back to the patient, what their expectations are and what their wishes are and what they want to do in the future, because that's what our job is, to make them better, not just physically, but also mentally.
We've preserved your nerves and your vessels. So can you just point your toes towards the ceiling? Okay, excellent. But the fact that you can lift up your toe to the ceiling means we've kept your sciatic nerve, okay? So you don't have a foot drop.
Yeah.
Tumour's out. You're gonna have function in your leg, but it's gonna take time.
Yeah.
That's gonna be the long-term work that we need to do, okay? Do you have any questions for me?
No. I just want to go to sleep.
Okay, all right, okay.
Paul and I knew that we needed to remove this cancer completely, but preserve those organs. And fortunately, we could do that because those structures weren't involved. They weren't invaded by the tumour. We were happy that we got the cancer out.
With her life-saving surgery complete, all Jolene can think about now is getting home to her kids. James has made an astonishing recovery from his major brain surgery. So good, in fact, that he's already heading home.
This happened very quickly because I came in here early Thursday morning, Friday, Saturday, Sunday, and now it's Monday. So that's like 4 days, which has gone in quite a blur. Good morning, sir.
You're all packed up?
I am just packing my bag now.
We can have a look at your scar. Looks pretty good.
Pretty good, huh?
Yeah, bit of swelling there.
It's quite interesting. I was shaving this morning and I was around here thinking,
careful.
why isn't that moving? And then I suddenly realised it was actually coming right round here.
Yeah. How are you feeling?
I'm feeling very good. I'm a bit tired, definitely, in the afternoons.
You'll find over the next week or 2 or 3 that will just get better and you'll get back to normal.
How long, in terms of the recovery period like that, is it going to be 6 weeks?
Yeah, by 6 weeks you should be largely back to normal.
OK, all right.
All right, so...
Thank you. I'll see you next month.
See you then.
Thank you very much. Bye.
Today is a good day because James has made a complete recovery. He hasn't had a stroke. Everything's gone perfectly. It's the best feeling when someone goes home, and James is going to start work, I think, in a couple of weeks, which is just fantastic.
I feel absolutely ready to... Well, I'm not ready to start studying or working again, but I feel perfectly happy not to be here taking up space.